I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to give an introduction to the techniques in peripheral vascular intervention. Uterine fibroid embolization is mainly performed by interventional radiologists worldwide, but in countries like Pakistan, unfortunately, interventional radiology is mainly limited to the private sector, and therefore non-affording patients cannot benefit from their service. At Rawalpindi Institute of Cardiology, we took the initiative of starting this intervention for these non-affording patients who are high-risk cardiac patients. As an example, these patients have a valvular heart disease, which requires prosthetic valve implantation, but since these patients have symptomatic fibroids which are bleeding, and these patients need repeated blood transfusions, and these patients are surgical turned down by gynecologists in other hospitals due to high anesthesia risk. So these are the patients who cannot be started on warfarin till the symptomatic fibroids are taken care of. Similarly, patients with dilated cardiomyopathies, with low ejection fractions, these are the kind of patients whom we treat at Rawalpindi Institute of Cardiology, and we treat them free of charge. Now, some facts about uterine fibroids or leiomyomas. These are made up of the muscle cells that make up the uterus. They are extremely common, present in up to 70% of African American women. One of the commonest causes of hysterectomy in women. These are mostly benign, non-malignant tumors in the uterus, and the chance of cancer in fibroids is 1 over 2500. So it's very rare. Uh, there is no intervention required for asymptomatic fibroids. All you need to do is just carry out yearly ultrasound for follow-up. And the fibroids rarely come solo, they are usually multiple. But it's very important to remember that cancerous fibroids grow in size very quickly. So after the first incidental detection of fibroid, repeat ultrasound should be done at 3 months to see the growth rate. Now, a fibroid in the wrong place in the uterus can cause infertility. Fibroids can be either intramural, submucosal or subserosal, but pedunculated submucosal fibroid is in the cavity of uterus and occupies the space where fetus has to be accommodated. Intracavitary fibroids are more likely to be expelled in the weeks and months after embolization. Although many patients tolerate fibroid expulsion well, expulsion of larger fibroids may cause lower abdominal pain. It's important to remember that both single and multiple fibroids can be treated with uterine fibroid embolization, and all fibroid locations are eligible for embolization. Up to 80% of these fibroids are asymptomatic, and their main symptoms are either prolonged or heavy menstrual bleeding or symptoms due to the bulky uterus, which could be pelvic pain and pressure, urinary frequency, hesitancy, retention, painful intercourse, constipation, back, flank, or leg pain, or reproductive dysfunction. The heavy periods, prolonged periods, bleeding after intercourse, these are symptoms caused by fibroids that are eroding into the lining of walls of uterus. Pain and pressure symptoms on bladder, etc. These are seen with fibroids growing towards the outer surface of uterus, which increases the size of the uterus. Pressure or mass effects may present sometimes with urinary symptoms when fibroid is sitting on top of the urinary bladder, and the women need to go to the bathroom very frequently. They always start in the uterine wall, and then they either grow towards the outer surface of uterus or grow towards the inner lining of the uterus, which is sloughed off during periods. Fibroids towards the outer surface usually cause an enlarged bulky uterus, which is described in terms of weeks of pregnant uterus looking at its height in the abdomen. What's important to know is that all of these symptoms can be relieved with uterine fibroid embolization. Myomectomy should probably be the first procedure considered for a patient with fibrosis and a desire to future fertility. Myomectomy has better reproductive outcomes compared to fibroid embolization in the first 2 years after treatment. And embolization can be considered for a patient who is not a candidate for myomectomy or does not wish to undergo that procedure. For example, large number or large size of fibroids, history of previous surgery, or comorbidities which increase operative risk. It's important to remember that if the patient has just a couple of fibroids and she definitely wants to get pregnant in future, consider myomectomy, because literature suggests that scooping out those one or two fibroids preserves the uterus in such a way that women are more likely to have a normal pregnancy. So myomectomy is the recommended option. Women who refuse surgery should be clearly told that we don't know what their fertility rate will be after embolization. However, 50% of women can still get pregnant. In some women with large and multiple fibroids, doing myomectomy removes so much of uterine tissue that it probably becomes very difficult for that uterus to carry a baby, and in those cases, again, fibroid embolization can play a role. This procedure was first described in 1995 in France for treating uterine fibroids. Before 1995, people used this technique to stop bleeding of postpartum hemorrhage. These postpartum hemorrhage patients realized that after this treatment, their symptoms related to fibroids also got better. So then they went ahead with this first trial of 16 fibroid patients, and their symptoms significantly improved.
Uterine fibroid embolization procedure, UFE. UFE is a safe, effective treatment for fibroids that has been performed for nearly 20 years. It is one of several treatments that may be used to treat fibroids in the uterus. Uterine fibroids are non-cancerous growths that develop from normal uterine muscle cells. There are 4 types of fibroids that develop in or just outside of the uterus. Submucosal fibroids grow into the uterine cavity. Intramural fibroids grow within the wall of the uterus, and subserosal fibroids develop on the outside of the uterus. Pedunculated uterine fibroids occur when a fibroid tumor grows on a stalk, resulting in pedunculated submucosal or subserosal fibroids. All fibroids require a supply of blood to survive and grow. UFE takes advantage of this fact to target the fibroids. Uterine fibroid embolization is a minimally invasive procedure. UFE does not remove the uterus or the ovaries. A small incision is made in the leg to gain access to the femoral artery. A long flexible tube called a catheter is then inserted into the femoral artery. It is guided up the femoral artery and into the artery that supplies blood to the uterus, called the uterine artery. The catheter is then guided to smaller arteries that supply blood to the fibroids. Uterine fibroid embolization delivers tiny microspheres to the artery that supplies the fibroids, cutting off the blood flow, causing the fibroids to shrink. The tiny microspheres are injected through the catheter and travel through the blood vessel. Since the microspheres are more than 60 times larger than red blood cells, they plug the tiny vessels that red blood cells travel through to feed the fibroid. The procedure is repeated in the uterine artery on the other side to make sure that all blood supply to the fibroids has been cut off. All fibroids are treated simultaneously. Once the blood supply to the fibroids has been blocked, the fibroids begin to shrink. There is no scar tissue and minimal blood loss with UFE. Recurrence of the fibroids with uterine fibroid embolization is rare. Most women are able to return to light activity within a few days of the UFE treatment and are usually back to work and normal activity, on average, within 11 days.
Coming to the anatomy, aorta divides into right and left common iliac arteries, which further divide into external and internal iliac arteries, and internal iliac arteries on both sides give rise to uterine arteries, which can easily be identified on this image as tortuous arteries going to medially inwards. So they are easy to identify, and from these you can see the supply to the fibroids going through these tiny tortuous corkscrew type branches. Now, how do we do the procedure? It's simple. You gain femoral access, arterial access with a 4 or 5 French sheath. Then you need a 4 or 5 French cobra catheter to selectively engage common iliac artery. What's important to remember that uterus has bilateral supply, so you have to embolize both uterine arteries, both sides. You can start contralaterally or you can start ipsilateral, it does not matter, whichever is convenient for you. So you selectively go into the iliac artery, one of the common iliac arteries, then you selectively go into the internal iliac artery, and from there you go into the uterine artery, and then uterine artery has a descending branch, then it has a horizontal segment, and then it has an ascending limb. So what you need to do is go into the descending branch, then horizontal segment, cross it all the way, and then go into the ascending limb. And this is the point where you stop and start doing your embolization, either with the cobra catheter that you've brought in, the 4 French, and if the artery is smaller and cannot accommodate this 4 French cobra catheter, then you have to bring in a peripheral microcatheter like a ProGrid 2.7 or a direction microcatheter, through which then you need to start doing embolization once it reaches the ascending limbs of the uterine artery, and you keep injecting till the flow gets stagnant, and then you stop, and then you do the same procedure on the opposite side. This picture is to again explain the ideal position for the microcatheter for embolization. So you can see internal iliac artery, it has a descending segment, then it has a transverse or horizontal segment, and at this point there is a cervico-vaginal branch of the uterine artery that's coming off, and then it starts ascending up. So we can call it an ascending segment of the uterine artery. So the purpose is, our effort is to avoid the cervico-vaginal branch, and therefore we place the microcatheter or the C4 diagnostic catheter into the ascending limb of this uterine artery, and this is the place where we start injecting the embolization particles. Now, there are two important branches of the uterine artery in addition to the vessels into the uterus itself. One of these is the cervico-vaginal branch, which I just explained that it arises from either the mid to distal portion of the transverse segment or the proximal portion of the ascending segment. These branches collateralize with ascending branches of the vaginal artery. So there is a concern that because this vessel supplies nerve fibers and other structures in the cervix, its preservation may be important for sexual response and experience. So there has been a significant debate in recent years over the importance of excluding this vessel from embolization field. Although the studies presented at recent Society of Cardiovascular and Interventional Radiology meetings indicate that negative effects on sexual function are rare, and embolization should be performed with the catheter tip beyond the origin of the cervico-vaginal branch if technically feasible, excluding it from embolization. However, this is important that in many cases this will not be possible because of vessel tortuosity or the location of the branch origin. So including cervico-vaginal branch in the embolization field is not considered a technical fault. If you compare this picture with the previous one, you can see how tortuous this uterine artery is. You just cannot differentiate between the transverse segment and the ascending limb. In these cases, if you try to go very distal, there is high likelihood of dissection or arterial spasm due to your catheter, microcatheter. So even a more proximal position is preferred in such situations. And even if you stay in the proximal part of the transverse segment, that's okay for such situations. You just cannot make out even where the cervico-vaginal branch is. So in these cases, go for a more proximal position. Now this is how the PVA particles are supplied. Just as an example, these are the Boston Scientific's PVA particles. You can see that these are supplied in different sizes. Now there are some small sizes, large sizes. So commonly used sizes are 355 to 500 and 500 to 710. However, there is also a recommendation that ovarian artery is the one that gives a lot of a lot of cross filling to the uterine artery, and when you go into the ascending limb, you sort of also avoid the anastomosis where the ovarian artery could join the uterine artery, Even if you are behind that, but if you are using large size particles like 500 to 710, you are safe in a way that they would not go into the ovarian artery and embolize the ovary as well. So you need to be careful there. You also have calibrated microspheres. Now, in the diagram, in the picture, you can see by the name of Embozine, again Boston Scientific. So these calibrated microspheres are more uniformly sized than the standard PVA particles that I've shown previously, and this results in a more predictable level of embolization and also minimizes the clogging of the microcatheter, which is a problem with standard PVA particles. I'm going to show you a live in a box case now, which I recorded at Rawalpindi Institute of Cardiology. And in that, I'm also going to show you how the PVA particles come and how we prepare these particles for the procedure. So let's go through the video, and I think that will clarify a lot of doubts. Another case, just to clear further concepts, 45-year-old lady awaiting prosthetic mitral valve replacement. She had fibroids with menorrhagia requiring blood transfusions. Her hemoglobin actually used to drop up to 5 grams per deciliter. So she was unable to start warfarin, and gynecologists were not willing for surgery due to high anesthesia risk. So right femoral access, you can see a pigtail in the aorta just before the bifurcation, and then you can clearly see the two uterine arteries going inwards with a lot of tortuosity, and you can see the big ball-like fibroid which lightens up with the contrast, and these corkscrew type branches going towards the uterus. So we went for the contralateral embolization first. This is a 4 French Cobra catheter which is in the internal iliac artery right now, and we can see the uterine artery from here. So at times you have to change the angulations to see how the how the uterine artery is originating from the internal iliac artery. It becomes challenging to see the origin. So you have to go LAO, RAO, AP. You have to see which is the best view to engage it. Now this is selective engagement of the selective cannulation of the uterine artery on the left side, and from here now we will look for angulations that are best to go into the ascending limb so that we can start embolization. Now here you can see that we are injecting the particles carefully. You start injecting them into the ascending limb, and you are careful not to force them with too much pressure, that they start going back as well. And then you have to see when the flow starts stagnating. You must remember that the aim of embolization is not to occlude the main uterine artery, but to occlude the vessels that supply the fibroid, while sparing the vessels supplying normal uterine tissue as much as possible. So you just stop when the flow starts stagnating. Or if it starts backflowing, then you have a chance of letting it go into the iliac artery. Therefore, you need to stop there. And now we can see that the flow has stopped, and this embolization on this side, left side, is complete, and we are moving to the right side, and this is selective engagement of the right uterine artery. After embolization of both sides, now you can see the comparative DSAs. On the left, it's pre-intervention, and right is the final result post-intervention. So what's important now is the post-procedure care. So for several hours after embolization, patient may experience abdominal pain, which is due to ischemia. And you need to give the patient non-steroidal anti-inflammatory drugs and IV narcotics at times. Severe pain usually lasts for 6 to 12 hours. Usually disappears completely in about a week's time. So you can discharge the patient on anti-inflammatory medication and stool softeners. Patient should be advised to avoid sexual intercourse for 1 week post-procedure. If the patient has a coil in place for birth control, it does not affect fibroid embolization, so you can leave it in place. Patient can return to work in 1 week. There is something called post-embolization syndrome, which can lead to readmission in up to 10% of patients. It usually consists of loss of appetite, nausea, and malaise. Rarely, fever can also be there. MRI is an excellent investigation, pre-procedure and post-procedure for follow-up. So for workup, pre-procedure, you can see an oval-shaped fibroid lying in the uterine cavity, and then post-intervention, you can see fibroid completely vanished in 8 months' time on MRI after uterine fibroid embolization. Now this is another scan for another patient. You can see the large fibroid, and you can see how compressed the urinary bladder is. That's what causes the pressure symptoms. And then look at the scan after 1 year and after 3 years, and you can see the size of the fibroids, and you can see the pressure relieved over the urinary bladder. 90% of patients were satisfied with bleeding symptoms at 1 year, 80% satisfied with pressure symptoms at again 1 year. 3-year data with fibroid registry, 86% patients were satisfied. ME trial, 10-year outcome, more than 2/3 patients were satisfied. So 40 to 70% shrinkage of the uterus and fibroid occurs at 6 months. And remember that even large fibroids more than 10 centimeters can be treated safely. So embolization is as effective as surgery for symptom control, with the caveat that about a third of women may require a second intervention by 5 years. So remember that persistent symptoms after fibroid embolization can be due to incomplete fibroid infarction, and heavy menstrual bleeding may not improve due to the presence of comorbidities such as adenomyosis, endometrial polyps, or other endometrial disease, or coagulation defects such as von Willebrand disease. This is a trial which looked at this question of size. Does the size really matter? So this is a prospective single-center study of 121 patients which looked at complications. In the trial, large fibroid size was taken as more than 10 centimeter, or large uterine volume more than 750 cubic centimeters, or large number of vials used for embolization which had to be more than 4, and these were then seen for complications, and there was no complication difference seen in comparison to embolization of smaller fibroids. The only difference was that the symptoms took longer to resolve in large fibroids. Very few absolute contraindications to embolization. Pregnancy. So every patient must undergo a pregnancy test on the morning of fibroid embolization. And then gynecological malignancies or current uterine or adnexal infection. Complications of fibroid embolization: abdominal pain like severe pain of menses for at least 6 to 12 hours. Chances of amenorrhea may last for up to a year. Infection, fibroid expulsion, venous thromboembolism, or complications related to catheterization. During the consent process, it is important that patients should be informed that symptomatic relief may not be achieved in some women. Symptoms may return and that further procedures may therefore be required. Patients contemplating pregnancy should be clearly informed that the effects of the procedure on fertility and on pregnancy are uncertain. However, chances of pregnancy may not be any different than that seen in similar aged women with fibroids who are not treated with uterine fibroid embolization. Now, they usually have around 50% chances, that's what we tell them, 50-50 chances of getting pregnant later on. But if pregnancy is the priority, then myomectomy is the treatment of choice. Now, next I'm going to show you a small video clip of Professor Peter Popovich from Slovenia, where I went for my training in fibroid embolization. The good thing about this center was that they gave us an opportunity to do the fibroid embolization hands-on on live cases. So what he's going to show in this small video is that if you have an emergency procedure for embolization, you can use a gel foam, making it into small particles, and then using that as embolization particles, whether it's postpartum hemorrhage where you need to use it. The good part is that it's not a permanent embolization, and it's an interim relief, and later on these particles will dissolve and the flow will re-establish itself. So for emergency purpose, it's a good embolization material. Okay, very simple. Okay, you just catch it, small, big. Okay.
Ще воно покличемо к сезону, де буде боліти.
Okay. Just feel it. Dajte mi 3 kot, petelinček mi dajte. Tipo one more with the...
To je voda?
Voda koncentrat. So this is contrast. Kola? Quanto se da? Yes.
20, 40 times. That's it. Depends. If you use microcatheter, you add it more saline or contrast. If you use 5 French catheter,
This is a diagrammatic representation of what Professor Popovich just showed us. You can see the gel foam on the top left corner, which has been cut down into small particles and inserted into the syringe, and then another syringe with a 3-way tap with contrast and saline mixed is used and to prepare this gel foam in the same way as we prepare the PVA particles, and then this is injected through microcatheter or a 4 or 5 French diagnostic catheter into the uterine artery to stop the postpartum hemorrhage as an emergency. Next, I'm going to show you a 3-minute clip of a live case that I did for Pakistan Live 2022.